All right, so we're going to be learning about IV cannulas today. There are three main reasons why somebody would have an IV cannula. Okay, the first is if they need hydration, so for just fluids, if you're dehydrated, if you've had heat stroke for whatever reason. The second is if you need IV medications, and the third reason is if you are if you're at risk for deteriorating. What I mean by that is, let's say your blood pressure is slowly going down and your heart rate slowly going up, and I see you're getting worse and worse, and I wait and wait, and all of a sudden you code and I'm doing CPR. We have medications that we would love to give you by IV, but we now need to insert the cannula. If your heart is not beating, what do you think your blood pressure is? 0. You don't have blood pressure, which means your veins are collapsed, and it is way more difficult to get an IV cannula in at that point when a code is happening, okay? So if you notice that your patient is starting to deteriorate, or if they are at risk for deterioration, you put the cannula in when it's easiest to put it in, just in prep for if things go south. Make sense? Okay. Which brings us to the point of removing a cannula. When should a patient have an IV cannula removed? Well, if they're not meeting any of those three criteria, then we don't need it in, and we can pull it out. So today we're going to be talking about that insertion and removal. IV cannulas are amazing, particularly because what they allow us to do. So if you have an IV cannula in somebody, you can give them IV medication, and it starts working within about 30 seconds, and it'll reach its peak effect within about 5 to 10 minutes, okay? Versus oral medication, which reaches its peak effect at around 45 minutes, okay? The other thing is oral medication has to be digested and go through the liver and be processed, and it becomes it loses its effectiveness as that happens. Whereas with the IV, it goes straight into a vein, which immediately goes to the heart, gets pumped around the body into the brain within minutes at its most effectiveness. Make sense? All right. One of the most obvious reasons for an IV is if somebody's feeling nauseous. If I go up to you and you're puking your guts out, I go, look, I've got an antiemetic tablet. Can you just take that for me now, and it'll kick in 45 minutes? If they manage to swallow it between now and 45 minutes, what do you think is going to happen? They're probably going to puke it back up. Whereas with an IV, you just give them the antiemetic through the IV, and within minutes they feel relief. Makes sense? All right. So I've got this whiteboard here. You guys can take pictures of it later. What I'm going to do is I'm going to just kind of talk you through it so that you have a better understanding of all this information, okay? So when it comes to IV cannulas, size does matter, okay? ENs do not insert IV cannulas at this point. However, I suspect that within the next 5 years, ENs will start learning how to put them in. So I will be demonstrating to you guys today how it would go in, okay? And it also helps for you to have a better idea of what you're dealing with, because right now ENs are allowed to do everything associated with IV cannulas except the insertion part. Okay, so in terms of size, you can see the colors on the package, and then there's colors on the actual cannula itself. See how that's yellow, and the package was yellow? And this one, package is green, and it's got green here, okay? That's how you can tell the size. Now, the bigger the number, the smaller the needle. I'll let you pass these around. Yellow is a 24 gauge, green is an 18 gauge. Green is 18, it rhymes. Blue is 22, it rhymes. That's how you remember it. We use smaller needles and smaller gauges generally for babies or nurses who struggle to cannulate, okay? The reason being, obviously, it's easier to get a smaller needle into a big vein. However, why do you think we prefer to use a larger cannula if we can get it in the vein and if it fits well?
It's easier to push stuff in?
Absolutely. So the cannula, the tube, is wider, which means putting fluid through, it flows a lot easier rather than trying to push it through a small tunnel. The other thing is when you put a cannula in somebody's arm, you're making a hole in the body. The body doesn't like holes, so it always tries to block that hole by creating little blood clots, okay? Well, that little yellow 24 gauge is going to occlude or be blocked off a lot quicker than the green. And what I find is that, yes, it might be nicer for the patient because we put the 24 gauge in, so it's a smaller needle, but then within a day it blocks off, and all of a sudden we need to poke them again. Whereas if we just went with the bigger needle, one time poke, it's good for 3 days, and it's less likely to block off. Make sense? Personally, I prefer to be poked once with a bigger needle than multiple times with lots of little needles.
Once you keep bangs on we can do blue ones.
Absolutely. So
that's where I put a blue one because they took the other and it's like one on one.
yes,
Yeah.
absolutely. So that's when you'd use the small one, and it is acceptable to use the small one. It's just you need to watch it more closely because it does become occluded a lot more quickly, and then you cannot give fluid nearly as quickly through the small tunnel. Okay. All right. So those are the sizes. Now, what we can do to prevent it from occluding is to flush the cannula. And what a flush means is we're running salt water, normal saline, just through the cannula to make sure it doesn't occlude, okay? We should be flushing with a minimum of 3 mils, and you just use a regular, where are they? Just a regular syringe, minimum of 3 mils, okay? And you should be doing it every shift. So what else are you supposed to be doing every shift? OBS and your head to toe assessment. So you might as well do it all at once, okay? When you do your flush, you're going to do it using a turbulent technique. So that means stop, go, stop, go, stop, go. 1 mil every stop, go. Okay, I'll walk you guys through that and I'll demonstrate it. And you're also you're gonna flush once a shift, and also you're gonna always flush before and after any medication, okay? Now, while we're flushing, or even right before we flush, since we're doing our head to toe assessment, we're going to be assessing the IV site itself using what's called VIPS, okay? Which stands for Visual Infusion Phlebitis Score. Now, you can grab one, pass it on. You'll notice in the bottom corner here, this is where we record our VIPS score. So what we do, and I want you guys to write this right now. I want you to put in today's date, okay? And it's the afternoon, so we're going to put in the afternoon, and you see the little triangle slot where it says score. You're gonna put 0, because we're going to pretend our IV cannula VIPS is 0. And then you're going to initial. And you do that every shift.
Please say that again.
Pardon?
Please say that again.
Okay. So put in your date, and then you've got this, you see under PM, the score section. So you're gonna write 0 for now, and I'll explain it. And then you'll see where it says initial, you initial. And that's how you show that you've looked at the site and assessed it. Now what does that 0 mean? Well, if you look at the top of the page, 0 means healthy IV site. There's no sign of phlebitis, which is like infection or irritation. And it looks okay. So the action that you're supposed to do underneath, continue to observe, document at each shift, and replace the dressing if it's not clean, dry, and intact. Pretty straightforward, right? Now, look at the next one, the next score, 1. If your patient has pain at the site, erythema, what's that? Redness at the site, or tenderness, well, let's look at the actions. Continue to observe closely, document at each shift, and considering having the doctor review it, okay? And replace the dressing if not clean. So basically it's, okay, could be a sign of infection starting. We're going to keep a close eye on that site and monitor it. Look at score 2, pain, redness, swelling, palpable venous cord. That's where the vein is swelling up and you can feel along it, okay? And discharge. Does that sound like an infection starting? Absolutely. What are we supposed to do? remove that IV cannula, okay? You'll see there is a section for date and time of removal. Do you guys see that on your page at the bottom? And the reason for removal. So you would write, reason for removal was there was discharge at the site. Reason for removal, the patient was in a lot of pain.
Could you just do like VIPS score 3?
Well, you're also going to document your score here. So you're going to document your score in your assessment section, the one you just practiced filling in. So you'll already have written the score, but now in that section you want to write exactly what part you noticed, okay? Same with VIPS 3 and VIPS 4, they just gradually get worse and worse. So you're going to remove your IV cannula at that point. Any questions about this document? No? Okay. Then if you flip it over, if a new IV gets inserted because you've removed the infected one, you start all over again with your documentation of this new IV insertion site. We'll practice more filling out these pages later. Okay, so far we've gone over the size, flushing your cannula to make sure it doesn't become occluded, and we've talked about VIPS, okay? So now we're going to talk a little bit about timings. So your cannula, which is in your person, is good for 72 hours from when it is inserted. So let's say I insert a cannula. So grab your VIPS page. Under device 1, I want you to write the date and time right now. The site, we'll say it's the left forearm. The size, we'll say it's a 24.
Just put 24 as like 24,
You can write 24G if you'd like, or you can just write 24, and then we would initial.
What's the size, sorry?
24, we'll say. Now I want to,
Left
oh,
forearm.
site, left forearm. Look below that, you see where it says recite due? I want you guys to determine the date and time the recite would be due, knowing that it can be left in for 72 hours. So what's the date today? The 26th, so at 1:20, which means 27, 28, 29, so the 29th at 1:20, it must be removed, or by 1:20, it must be removed, regardless of what your VIPS score is.
Can we remove them?
You can. So like I said, ENs can do everything except insert, but you are also allowed to remove, okay? All right, so we've talked about removal after 72 hours. Now we're going to talk about IV lines. Have you guys learned about continuous versus intermittent infusions? No? Okay. Continuous infusion is when I have an IV line and I connect it to the patient and it just slowly drips water, saline into them.
Without the pump?
Whether a pump is involved or not doesn't matter. It just keeps dripping it for the next 2 days. I'm just slowly rehydrating them. That's continuous. Intermittent is when you have antibiotics due at 8 o'clock, 2 o'clock, and 8 o'clock again at night. So I would connect your IV antibiotics, let them run through over an hour, disconnect them. Then I come back at 2 o'clock, connect your IV antibiotics, let them run through over an hour, disconnect them. That's intermittent, okay? If you have an intermittent infusion, you generally change the line every time, okay? If you have a continuous infusion, let's say the doctor wants your patient to have continuous IV fluids for the next 5 days, okay? Well, every 24 hours, you're gonna change your IV lines, just to make sure there's no bacteria or anything growing in them.
That's the giving set, yeah.
The giving set, absolutely, correct, okay? So your actual cannula in your hand can stay in for 72 hours. The giving set, the IV line that you attach to it, needs to be changed every 24 hours. Okay. 2 nurses are to double check and co-sign all IV fluids at the patient's bedside. Technically, that includes when you flush the cannula. Realistically, that doesn't always happen in the hospital setting, okay? But your IV bags attached to your giving set and your IV medications, you will always have to show another nurse. Any questions about that? No? Okay, I'm going to briefly talk about CVADs just so you have a basic idea, and we're going to cover that a little bit more later. CVADs stand for central venous. Sorry, before I get into CVADs, I'm actually going to demonstrate the cannula to you. Okay? So, if you guys want to come close. Now, I'm not going to show you the proper technique and everything because today the focus is not on teaching you how to insert a cannula. I just want you to get an idea of how it works, okay? Realistically, if I was doing this on a patient, I would have a special cannula kit. I would have gloves on to protect myself because I'm about to deal with blood potentially. And I have a few other stuff set up. So this is your needle. You guys can see that the needle is actually coming through the catheter, okay? So I go into the patient's vein, puncture. Once I'm in the vein, I start slipping the catheter off the needle, okay? Now this has a special safety, so I don't actually have to fully pull out the needle and expose myself to a puncturing needle stick, sorry. I can just push the button and it retracts, okay? So a big misconception and a big fear of patients is they go, oh my goodness, and they think they have a needle in them because they don't actually see that retraction. It's not a needle that's in them. What they have in them is this little plastic tube. Okay, so you can pass that around. Now this plastic tube can kink, which is why if you insert the catheter right here, they bend their wrist, the plastic tube will kink while their wrist is bent, and that's going to impact any medicine or fluid that you get through there. So you always want to just make sure that their arms are straight when you're dealing with it, okay? That's a really small, the plastic part is what we call the cannula, okay, or catheter. Now, we're going to move on to talking about CVADs, central venous access devices. This is your IV cannulas, just obviously go in the arms, and they only go up until here. We can insert it in the hand, the forearm, or right here, okay? CVADs go here, or here, and the catheter is about this long. And it gets fed in through the vein until it drops right above the heart. So any medicine that you give through CVAD, you're literally injecting that medicine immediately into the heart, okay? Some reasons we might use CVAD, one of the biggest ones is chemotherapy, okay? So chemotherapy, we are all well aware that it's cytotoxic. It's highly dangerous if it gets in on the skin, okay? We want it to go in the veins and we want it to go in the heart. We do not want it to go anywhere else. Well, the problem with these cannulas is they can tissue. Meaning I put it in the vein, but sometimes I might miss the vein and end up in the skin, or it might shift a little bit and move out of the vein and be in the skin, okay? That's called extravasation. If I inject chemotherapy and instead of going into the vein, it goes into the skin, it's actually going to burn through the skin from the inside out, and there is no stopping it. It's very bad. So with patients receiving chemotherapy, when we use a CVAD, we know that that catheter is 100% in the vein and disposing the medication into the heart where it immediately gets diluted and dispersed around the body. There's no risk of burning through tissues. Make sense? The other cool thing about CVADs is they're long-term. So your PICC line, which is inserted in the arm, can be kept there for up to 6 weeks, rather than your cannula that's only good for 3 days. So if you need weeks and weeks of antibiotic treatment, IV antibiotics, we might put a PICC line in, okay? PICC lines generally just dangle out. It's a couple of cords that dangle out from the arm, okay? I'll show you some pictures later. Then we have the Hickman, which is some lines that dangle out from the chest or the neck. Same sort of idea, they just have different names. And then we have the port, and the port is a little different. It is like a, can you get me the bottle in the medicine cabinet there? Just on the left? Yep, bottom shelf, middle, bottom shelf, middle, that's it, perfect. So a port actually looks like this lid, and it has a rubber stopper in the middle, and it's just the lid, and it sits under the patient's skin. And we have a special needle, so we come along, clean the site, and insert the needle, and it's just really quick, and it's always guaranteed to be in the right site, and it's still considered a central venous access device because then the line is inside the person. Cool thing about the port is because it's under the skin, they don't have these lines dangling, so they can go about their daily business until they need that site accessed. Okay. We also use central venous access devices for patients that are difficult to cannulate. Okay. So if we can't get their veins, and we desperately need to get IV medication into them or fluids, we'll put a CVAD in.
How long do they last?
So like I said, the PICC line lasts for 6 weeks. The port and Hickman's, I'm not sure exactly how long, but I believe at least a year. Okay, so much better than this 72 hours. Any other questions about that? And we have talked about, final thing to talk about. Actually, a couple things. So first off, we'll talk about terminology here. Saline, you guys have heard of that? It's the exact same thing as normal saline, which is the exact same thing as NS, which is the same thing as NaCl. Doctors will write it any of those ways when they write an order, so you just need to learn that. Hartmann's, normal saline is salt water. Hartmann's is salt water plus extra electrolytes and some extra stuff in it, okay? So the doctors might give that to certain patients rather than normal saline. Hartmann's is also called compound sodium lactate, which is also called Ringer's lactate. Okay. CCs, some doctors might give 100 cc's of fluid. CC's is a very old school way of just saying mils, how many milliliters you're going to give. And finally, KVO is the same thing as TKVO, which means to keep vein open. So when you've got a cannula like this, again, it's a hole in the body's trying to clot it up. And so to stop that from clotting, what we do is we just run fluid through continuously. But if we're worried about fluid overload on a patient, we want to run that very slowly. So the doctor might, rather than giving you a rate, they might just say TKVO. Keep that vein open. And you will run it at 20 to 30 mils per hour, normal saline. No matter where you go, that's the standard. Does that make sense to you guys? Okay. Final thing, and I just briefly mentioned it, is when you do have IV fluids going, you want to watch out for signs of fluid overload. Your signs of fluid overload are the exact signs and symptoms that a person with congestive heart failure might experience. The reason being, when a person has congestive heart failure, their heart is struggling to pump normal amounts of body fluid around the body, right? Well, when you get fluid overload from an IV, the heart's going to struggle to pump that extra fluid, which results in the same symptoms. So what are those symptoms? Shortness of breath, edema to the lower limbs bilaterally, increase in blood pressure, and a cough. Okay, they start coughing as fluid. Basically, fluid could be building up in the lungs or it could be building up in the legs. If you suspect your patient is experiencing fluid overload, you stop the IV and you notify the doctor. Okay. Sorry, one last thing, backtracking a little bit to the extravasation. When a patient, let's say that the cannula tissues, if it's medication, you need to get a doctor to review it to determine if the medication is going to cause tissue damage. However, if you've only had normal saline running through that, salt water essentially, and the hand has swollen up because it's tissue, the body will naturally reabsorb the salt water over the next few days or couple of weeks. So although it looks uncomfortable and horrible with the swelling, the body will naturally absorb it. It's not a big deal. You
Will
just
that
remove the
affect-
cannula.
Does that affect the blood flow to the hand?
Nope. Not if it's just normal saline.